guys, we are on to chapter 3, which is a range of motion. So we'll be diving right in there. If I can get the slides to advance. All right, so with range of motion, we're going to be talking about range of motion, and one really important point that I want to make right off the bat is that range of motion and stretching are two completely different things. In the clinic, you're going to hear these terms used pretty much interchangeably, but this lecture is focusing on range of motion. The next lecture, chapter 4, is going to focus more on stretching. So as we go through, I'll kind of talk about the differences between range of motion and stretching. So with range of motion, we're talking about moving joints or muscles as well, joints moving through their maximum range of motion. We need to do this periodically in order to maintain range of motion. And this is the main reason we use passive, active assisted, and active range of motion after injuries, surgeries, trauma, anything like that. Joints are going to tighten up. We talked about in modalities that arthrogenic muscle inhibition with swelling. So anytime there's anything going on with a joint, we're most likely going to see some loss of motion. We use range of motion activities to maintain existing mobility and to sort of move the soft tissues that surround the joint as well so that they don't develop contractures or adhesions. So again, we're maintaining existing mobility. That's range of motion. If we're trying to get new range of motion or trying to move beyond what the person currently has, that's when we start to get into stretching. So things that can cause a decrease in range of motion are things like disease processes, joint diseases or injuries, neurological insults or injuries, muscular diseases, surgeries, traumas, just inactivity. Being sedentary for long periods of time is going to decrease flexibility, or even things like sitting at a desk for 8 hours a day starts to lead to decreased flexibility and poor posture. Immobilization is also going to absolutely affect range of motion and decrease range of motion. You guys know this stuff, so quick review: passive, active, and active assisted range of motion are our major types of range of motion, and so we'll go into each one and why we would use each one. So passive range of motion, abbreviated PROM, is motion that is performed by an external force, typically us, the therapists. There should be no voluntary contractions by the patient. We can use gravity, machine, another person, even another body part. Again, the bottom bullet there, definitely remember this. Passive range of motion is not stretching. It's just moving them through their available range. And like I said, you're going to hear this a lot in the clinic. We need you to go range that patient's shoulder, range that patient's knee. Usually we mean stretch, right? We're trying to gain new range of motion, but passive range of motion and range of motion in and of itself is just taking the person through their available range. Active assisted range of motion is using some sort of external force to help or to assist with getting the range of motion. So there's a little bit of active. We can definitely get the person to interact with this one. So things like the pulleys, the towel stretch, wand, active assisted range of motion. If you're not familiar with any of those, please look them up. They're very common exercises, and we will definitely go over them when we are back together in lab. Active range of motion is when the person is going to actively move their joint or their body part through available motion. So doing an active hamstring stretch. Actually, that's stretching. That's not even range of motion. So just moving a joint through its available range of motion just to keep it moving. Again, to keep the joint, the synovial fluid moving, to keep the soft tissues active so that they don't get stiff and lose their flexibility. In modalities, we talked about CPM machines, continuous passive motion. So again, this is passive range of motion. It's right in the title. Usually a mechanical device done for hours at a time, most commonly done after surgical procedures. Most commonly, again, will be total knees. It is slightly used for a pain management method. And again, it does promote early recovery of range of motion. So your range, rate, time, that can all be programmed into the machine. And again, your patient's probably going to need some assistance getting in and out of that machine. Some other tools that we can use for range of motion clinically are things like a powder board or a skateboard. This is just a friction-free surface. You can also use things like a towel for table slides. And so you may have seen something like that before. And again, we'll go over those in the follow-up lab to this lecture. Some other things that we have in the clinic are reciprocal exercise units, so things like the bike. You may have seen a patient following a knee injury using a bike after surgery, not to make the full revolutions, but actually just sort of rocking back and forth to increase range of motion at their knee. The upper body ergometer, the UBE, the arm bike. Again, same thing. We can use that, use the good arm for the power while we're taking the injured arm along for the ride and getting more range of motion there. Again, this can also be used for reciprocal patterning. We can use it for endurance training. We can also use it for strengthening if we turn up the resistance a little bit as well. Some things to consider as far as factors that will play into range of motion are both intrinsic and extrinsic factors. Intrinsic factors are more of like the anatomy of the joint itself, the integrity of the ligaments, the tendons, the bone structure within the joint. That's going to have an effect on how much range of motion a person has. Other factors are extrinsic factors, things outside. So things like age. And again, usually as we age, we see decreased elasticity, the body tissue type and size of the patient, what kind of disease or injury process they have going on. Is this overuse? So those things will play into range of motion as well. Immobilization, as I mentioned, absolutely has an effect on range of motion. Some of the effects of immobilization are going to be loss of bone density. Just a few weeks into immobilization, bones start to demineralize and will start to get weaker. And that, again, is going back to Wolff's Law. We're not putting any force or any pressure on those bones. And so the body recognizes that, and it starts to they start to get a little bit weaker. If a person is immobilized for really prolonged periods, we do start to worry about osteopenia and osteoporosis developing. Cartilage is going to start to degenerate with immobilization. We talked about the fact that articular cartilage at the ends of long bones are nourished by the motion or the movement of synovial fluid. And so if a joint is immobilized, that synovial fluid is not going to be sort of moving around within the joint, and the cartilage is not going to get its nourishment there. So we're going to start to see increase in cartilage degeneration. Collagenous tissue fibrosis and adhesion. Again, this is typically of the soft tissue surrounding the joint. We start to see some inflexibility develop there. And again, if it's prolonged enough, you can actually start to see some adhesions or some contractures start to form. Muscles are going to start to atrophy as well. And so you'll have weakness start to develop in and around that joint as well after prolonged periods of immobilization. So indications or reasons why we would do passive range of motion. This is going to minimize the effects of immobilization if the patient's not allowed or unable to move. So again, we're hoping to maintain the soft tissue and the joint integrity, decreasing the risk of any contractures or adhesions from forming. This may assist in circulation to some degree. Again, better is going to be active or active assisted to actually get those muscles pumping. But even just getting the joint and the body part moving a little bit will be of more benefit than being completely immobilized. It can help to decrease pain. It can help assist in the healing process, again, by putting some normal forces along those lines of healing, and just to sort of help the person maintain their overall awareness of movement. I have received orders before to go in and do passive range of motion on a patient in the ICU who was comatose, again, for all of these reasons, just to help maintain their soft tissue integrity, helping to move circulation, maintaining that awareness of movement. There are also going to be times you'll have patients coming into your outpatient clinic who aren't allowed to perform any active range of motion yet. And I'm thinking there are fresh rotator cuff repairs are typically restricted on how much active motion they can do immediately following surgery. It's typically a couple weeks worth of passive range of motion. So it's okay for us to take their sling off and move them through the range of motion again so they don't get too stiff, and it helps with pain and all of those good benefits. Again, we're using range of motion, especially passive range of motion, to evaluate the limits of motion, get that soft tissue elasticity, see the end feels that we can get with our range of motion. We can also use it to demonstrate what we want the person to do once they're able to move on their own. We use it prior to passive stretching, right? So oftentimes we're going to do passive range of motion just to see what the patient has and determine, is this normal or not? You guys learned in Kines what the normal values were for all the major joints of the body. So by doing passive range of motion, we're determining, does this person exhibit normal range of motion or not? And if they don't exhibit normal range of motion, that's when we're going to cross that line into stretching and help them get that normal range of motion back. Again, so precursor to stretching. There is a video linked here. I'm not going to play it on here. I'm going to let you guys go into this hyperlink on your own that shows a physical therapist performing upper extremity passive range of motion on a patient. I want you to pay special attention to the shoulder, as it is one of the most common joints that you're going to be ranging. And they do show you most of the directions that you'll be using or ranging with that, the most common ones, which will be flexion, abduction, internal external rotation, and maybe some horizontal adduction as well. The video does also show elbow and some wrist and hand motion as well. Take a look at those, but again, we're going to focus more on the shoulder. And again, as soon as we get into lab for this, we will practice passive range of motion for all of these joints as well. Some indications for active assisted and active range of motion. As soon as the patient is allowed to actively contract, we're going to want them to start doing range of motion on their own, because you're going to get most of the same benefits as with passive range of motion. It'll also help to maintain the elasticity and contractility of the muscles, because now we're actually getting some active muscle contractions as well. We'll get some more sensory feedback. We'll help to reestablish any lost motor loops or neural loops. We talked about that after injury, how some of those are forgotten. This will actually be a better help to increasing circulation, can help promote healing and help to reduce swelling, because now again, we're doing some active motion. Contraindications to range of motion or active range of motion would be if the script forbids it. Like I said, some of our fresh rotator cuffs are not allowed to perform any type of active range of motion initially. And that's because motion would be disruptive to the healing process. They just reattached a tendon. We don't want them to contract that muscle at all to pull where they just reattached it. So some signs of disruption would be increased swelling, discoloration, mostly redness, heat. If any motion increases pain, we typically are not striving to increase pain when performing range of motion. Pushing outside the available range, because again, that then becomes stretching and not just range of motion. And if they have a blood clot or DVT, again, typically until that's medically managed, until they're anticoagulated, we're not going to be doing a whole lot with them in therapy. Some limitations to range of motion. With passive range of motion, again, this isn't going to prevent atrophy because it's all passive. We need actually active range of motion to prevent any atrophy with our patients. It's also not going to increase strength or endurance. Active can sort of start to help with that, but passive is not going to do that. Active range of motion will not increase strength of a strong muscle. If you already have strength in a muscle, doing active range of motion is not going to increase that strength at all. You need to add some resistance. You need to put a dumbbell on there, an ankle weight, some TheraBand, something to actually add some resistance if that muscle already has strength. You're also only going to develop skill and coordination in the pattern that you use. So again, if we're just doing typical range of motion, we typically stick to the cardinal planes for that. And so that's where our range of motion gains are going to occur. If we want to get into other planes, we'll need to add them to our routine as well. So again, just to kind of summarize, the goals and benefits of range of motion are going to be to maintain elasticity and contractility of the surrounding muscle groups and soft tissue, provide sensory feedback to the patient, especially if they're unable to perform range of motion on their own, provide a stimulus for bone integrity, and again, just keeping those joints congruent and moving, increase circulation to prevent blood clot formation, develop or enhance motor skills, prevent contractures from forming, decrease pain, hopefully slowing the rate of atrophy, and reduce emotional and psychological depression. Again, just giving that little bit of feedback, showing the patient that they can still move, they do still have some range of motion, can be beneficial for them. So how do we go about performing range of motion to get started? And again, we're going to practice this in lab. And I think you guys have probably done some practice with passive range of motion as well. But again, communicate with the patient, tell them what you're going to do and why you're going to do it. They're probably going to ask you that anyway. But this does require hands-on the patient. So before you, again, just grab onto them, make sure they know that that's coming and what you're doing. Determine which form of range of motion is going to be most beneficial. Do we need to do passive, active assisted, active range of motion? Make sure the patient is aligned properly, and this is a big one. If they're not aligned properly, you're probably going to see some compensatory motions with your motion. The patient should be comfortable. With passive range of motion especially, we need the patient to try to relax, and that's usually the hardest piece of passive range of motion, is getting the patient to relax enough that we're able to actually move them through their motion. So make sure they're positioned properly, going all the way back to procedures, right? The pillow placement, making sure that they're good and comfy, draped if necessary. If we need to expose any parts of them to be able to move them through range of motion, make sure that they're draped, and you protect their modesty as well. Support the body part that's going to be moved. Again, this is usually, again, with our hands-on, that we are supporting them. The patient needs to feel safe and secure, or again, they're not going to relax and allow us to do what we need to do. Watch your speed, watch your range. Whenever I'm ranging someone, I usually position myself in such a way that I can watch their facial expressions, because that's going to tell you a lot about how they are feeling and how they're tolerating treatment. You can see it in their face, even if they don't say anything to you, if they're in pain, if it's hurting. And again, we want to know those things, because that's typically not our goal with performing range of motion. So there you are. We are going to follow up this lecture with a lab, so stay tuned for that. And the next lecture is getting into stretching, so I will see you there.